Welcome everyone to the Ontario Caregiver Organization's webinar series. These webinars bring together caregivers and subject matter experts to explore topics of interest to caregivers. We do this to support and engage chosen family, friends, neighbors, really anyone who's caring for someone else. My name is Katie Muirhead and I'm going to be your moderator for this evening. We begin this gathering by acknowledging the Indigenous peoples of all the lands that we're on today. While we meet on a virtual platform with people joining us from across the province, I'd like to take a moment to acknowledge the importance of the land which we each call home. The land that I'm standing on is the traditional territory of the Haudenosaunee and Anishinaabe peoples, many of whom continue to live and work here today. This territory is covered by the Upper Canada Treaties and is within the land protected by the Dish with One Spoon Wampum Agreement. Today, this gathering place is home to many First Nations, Métis, and Inuit peoples, and acknowledging this reminds us that our great standard of living is directly related to the resources and friendships of Indigenous peoples. As team members at the Ontario Caregiver Organization, we are learning about the lands from which we work, exploring how we can be meaningful allies and how we can support the recommendations from the Truth and Reconciliation Commission. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our understanding of local Indigenous peoples and their cultures. We invite you to take a moment to reflect on the land where you are. And if you're not familiar with that, we will be sharing an interactive map that tells you which traditional territory your city or town sits on. And you can find that at native-land.ca. Our webinar today is called Improving Transitions from Youth to Adult Healthcare Services. Families and individuals caring for those who are transitioning from youth to adult healthcare may face many new challenges. In our webinar tonight, we will hear from caregivers to share their experiences, share some data on transitions, provide you with an overview of the transitions from youth to adult healthcare quality standard, and offer some additional resources you may find helpful. Folks, as I mentioned, are welcome to use the chat box throughout to ask their questions, and there'll be a Q&A period at the end. We are joined tonight by Rob Moore, a caregiver and member of the Quality Standards Committee, Laura McGregor, caregiver and associate professional faculty at Martin Luther University College and Wilfrid Laurier University, Michelle D'Amico, caregiver and the executive director of the National Initiative for Eating Disorders, and Kristen Cleverly, the co-chair of the Quality Standards Committee. You may notice Kristen responding to some questions if they pop up in the chat box, and she's going to be joining us at the end of the presentation for our Q&A portion. So to start us off, speaking from his perspective as a father of 3 children with fetal alcohol spectrum disorder, I'd like to kick things off and introduce you to Rob Moore.
Thank you very much, Katie. And first of all, I want to just thank all of you here that are here this evening. As a fellow caregiver, I know how valuable your time is, and for you to be able to take this time to join us tonight, I'm definitely looking forward to the Q&A session at the end and hearing your stories as well. I guess my story, I would say first of all, it's not really my story. It's more my older daughter's story. And it is with her permission that I'm sharing that with you here this evening. I got connected with the Ontario Health Council with particularly around this transitions from child to adult services because my daughter, my wife and I adopted her at the age of 6. She came from a background that was filled with, I would describe it as historical and developmental trauma. And over a multi-generational aspect. And so when she came to us, we were obviously beyond thrilled to be able to have her and her younger sister and her younger brother join us as well. And it was through those first few years that we really began to understand the aspects of complex needs and what that means from a caregiver standpoint. It wasn't until the age of 16, however, that my oldest daughter was diagnosed with fetal alcohol spectrum disorder. She had been diagnosed with attachment disorder and anxiety disorder before that. And life got really, really interesting at that point. We discovered very quickly, though, that if if you don't get the diagnosis until age 16, it's really too late in terms of being able to create a good transition from that child to adult services. And so we ran into a situation where essentially at the age of 18, when she graduated from high school, she was transitioning off to university. She was also looking at a new housing situation, and she was looking at new activities and so on, that life really became extremely difficult. And at the same time, it was in part to the fact that all of the support structure, all the people that she knew, everyone from a medical practitioner standpoint, was really no longer available to work with her. And the transition that happened really fell upon her primarily, and to ourselves as well. And so today I will we're still working through this. My daughter is now 22 years old, and I can tell you that as part of that transition, it took about 3 years for all of her reports and assessments and so on to get transitioned from her childhood, from her pediatrician to her adult services now. She's in a very difficult position right now. I can tell you that we have been able to secure stabilized housing finally. That's also sustainable. I can also tell you that we are very much looking, hopefully, that I will become a grandfather for the first time in May. It is in a situation where it's considered to be a high-risk pregnancy, though. So it's one that is a little challenging to work through, to say the least. So that's really my story as to why I joined the Ontario Health Quality Standards, because we really saw this as a gap of being able to work through that transition period at a time when there's so many other transitions that are happening as well. And when we get to later in the presentation, it's been my honor and privilege to share with you the 6 quality standards themselves. And I can certainly tell you that if these 6 standards had been in place for my daughter, that the story would be very different today. There's no doubt about that. So with that, I will turn it over to my next panelists.
Wonderful. Thank you so much, Rob, for sharing your story. And as you mentioned, you are going to be joining us again momentarily to share a little bit more about those standards, go through them with us. I'd like to invite Laura to pop on the screen. Laura McGregor will now share her perspectives as the caregiver for 21 years of a child with profound intellectual and physical disabilities. So the floor is yours, Laura.
Thank you so much to Rob and to all of you here tonight. I appreciate the opportunity to share a bit of my story. As the parent of a medically fragile young adult son with intellectual and physical disabilities, transition from youth to adult healthcare services was a difficult time. Until the age of 18, my son Matthew received complex coordinated care from a team of professionals with whom we had developed trusting and supportive relationships. Core team members understood Matthew's complex care and were sensitive to the demands placed upon my shoulders. Veteran parents, though, in my community shared with me that turning 18 was akin to falling off a cliff. When Matthew turned 18, I discovered the cliff was indeed real. He was discharged from all pediatric services, including respite support and home care, and transferred to the care of our family physician to start anew. Our very capable family physician had been involved in our son's care since birth, but she freely admitted that the scope of his care was at times beyond her comfort and expertise. For the previous 18 years, she had coordinated childhood vaccines and addressed straightforward concerns, but generally left the rest of his care to specialists. After transition, even something as, quote, simple as organizing Matthew's pharmacy needs became complicated. We would book hour-long visits with our family doctor to review Matthew's medication lists And together we identified referrals, but wait times could be lengthy. During Matthew's teen years, his health had been relatively stable, at least within the context of stable for a medically fragile teen. But following pediatric discharge, my son's overall health status became increasingly unstable, and we struggled on many fronts. We didn't always manage his chronic pain well, and organizing investigations and assessments was difficult. Something as simple as a blood draw or an X-ray was often fraught with difficulty. Adult care environments often didn't have the equipment needed for transferring or positioning Matthew, and their staff didn't always appreciate the need to approach his care differently. Many were hesitant to trust a mother with whom they didn't have a relationship, and Matthew's care was often compromised when I was ignored. The system was full of gaps, and Matthew fell through many. Matthew died 2 months after his 21st birthday, after several months of increasingly poor health. While I don't wish to minimize the fragility of his health, and I have always been aware of his life expectancy, I'm also aware of the research about healthcare outcomes associated with poorly managed transition, which means that I sometimes wonder if my son's story might have been different if we had managed his youth to adult healthcare transition better. Thanks for the opportunity to share my story, and I now hand it back to Katie and Michelle.
Thank you, Laura. Thank you so much for sharing your story. I do want to invite Michelle on the screen now, who's going to share her experience as the caregiver of a young person with an eating disorder.
Hi, thank you so much for the opportunity to be here today. So I'm the mother of a child who developed an eating disorder and many other accompanying mental illnesses as a teenager. And after experiencing the heartbreaking impact of eating disorders on both my family and other families, I left my career in the federal public service to work with the National Initiative for Eating Disorders. So prior to becoming ill, my daughter was a leader on our hockey team. She was involved at school and in the community. She had great marks. She had lots of friends. Then all of that changed. Her health deteriorated. Our doctor ran tests, and we finally learned that she had an eating disorder, a serious mental illness. Over the course of the coming months, she grew so ill that she could barely walk, and yet she wasn't considered sick enough for care. She eventually reached the point where her physical life was at risk and was admitted to hospital. Once she was in the system, it wasn't easy, but we were so grateful that she received the care that she needed, at least to an extent. She was discharged from the inpatient program when she was physically stable, but she hadn't really recovered from the eating disorder and the other serious mental illnesses that were coming into play. So we quickly learned that someone as young as 14 can refuse care, including medication, if their physical life isn't imminently at risk. This was devastating for us, given that her mental illness made it difficult for her to think the way that you and I would. That's where the importance of really the caregiver-doctor relationship came into play. I learned that consent can be a fine line and that the goal has to be getting to yes. When my daughter had passed out at home, she'd just gotten out of the shower and collapsed on the floor in a pool of water unconscious. I called the doctor right away and he told us to come to the hospital, but she didn't want to go in. So the doctor and I, we played off of each other a little bit. And I had to pick up on that conversation fairly quickly so that she eventually gave consent for readmission. It was him who said to her, "So I think I just heard you say that you agreed to treatment, right?" She shook her head yes, and that was the consent that we needed at that time. I applied the same technique as other situations arose. Then there was the question of what would happen when she turned 18. Although she still needed a multi-professional care team, we learned that the adult system of care was structured differently and that it wasn't recommended for her. And that was the recommendation from the care team that we had in the hospital that she was at. They recommended that we set up our own care team outside of the publicly funded system. So this was really terrifying to hear. She needed to transition out of the youth system, but where would she transition to? So we started working on a transition plan, but it was really dependent on my husband and I having the knowledge, financial resources, time, and skills to support a recovery. I couldn't return to work as my husband and I were central to the care plan, which included assembling a care team with a psychologist specializing in eating disorders at about $230 an hour every week for approximately 3 years. There were a lot of other expenses too. I also had to find a way to talk to our family doctor about a treatment approach, medications, and the role of mental illnesses. Then the question of confidentiality and consent was always at play. One thing that I did was book an appointment for myself, but brought in the stress that I was feeling because of her illness. The doctor couldn't reveal anything about the conversations with my daughter, but luckily she was interested in her well-being and listened to what I was saying. Planning ahead for this transition played an important role in her ongoing recovery. In my experience, what's needed is not only support for transitions in care, but a seamlessly publicly funded system of care that reflects the needs of the individual at the time when they age out of the youth system. Effectively, there needs to be something to transition to. Thank you.
Thanks, Michelle. Thank you so much for sharing your story, and to all of our panelists so far for sharing your personal experiences. As most of us know, these experiences are not unusual for those transitioning from youth to adult healthcare services. I'd like to invite Laura to jump back on again and walk us through some of the data on transitions to adult healthcare.
Thanks so much. The transition from youth to adult healthcare services is a vulnerable time for young people. Just as young people are learning to manage their own healthcare, oftentimes they must change healthcare providers and adapt to new services and processes in the healthcare world. And all of these healthcare changes come about just as they are transitioning to adulthood, a time of physical and social change. Next slide, please. The transition from youth to adult care also brings new challenges for parents and caregivers. Sorry, I think I'm a slide behind you. Just FYI, I think you're a slide ahead of me. That's great, thank you. Often parents and caregivers have been the primary caregiver to the young person. And yet, as the young person becomes capable of making their own healthcare decisions, they may decide to limit or even exclude caregivers from their circle of care. This can be very hard for parents to accept. For young people who require substitute decision-making, there are often challenges. Parents and caregivers must apply for legal guardianship for their own child, both for their person and property. Next slide, please. To give you a sense of how commonly this transition from youth to adult healthcare occurs, about 15 to 18% of young people in North America have a chronic health condition. About 13% of young people have at least one disability, and 2% have a severe or very severe disability. About 20% of young people have at least one challenge with a mental health or substance use disorder, and up to 70% of them still need care as adults. The majority of these young people will need to transition from youth to adult healthcare services. Next slide, please. Thank you. For these transitions, when these transitions do not go smoothly, young people and their caregivers can experience feelings of uncertainty and low satisfaction, a lack of access to healthcare services and information, gaps in service or a loss of follow-up adult care, and increased emergency department visits, hospitalizations, and negative healthcare outcomes. Can we move to the next slide, please? Thank you. To address these issues, Ontario Health, in partnership with the Provincial Council for Maternal and Child Health, created the Transitions from Youth to Adult Health Care Services Quality Standard. Next slide, thank you. What is a quality standard? Well, quality standards are a set of documents developed by Ontario Health that tell clinicians and patients what high quality care looks like. They focus on conditions or processes where there are large variations in how care is delivered, or where there are gaps between the care provided in Ontario and the care patients should receive. They are grounded in the best available evidence. So basically, the quality standards are meant to set a standard for what kind of care everyone in Ontario should receive, so that no matter where you live, you receive the same quality of care. Next slide, please. Thank you. The Transitions from Youth to Adult Healthcare Services Quality Standard was released this past February, and it covers care for young people aged 15 to 24 years. From all clinical populations, including young people with disabilities, special healthcare needs, chronic and/or complex physical, intellectual, or developmental conditions, or mental illness and substance abuse. Next slide, please. The quality standards are intended to help patients, residents, families, and caregivers know what to ask for in their care. They're meant to help healthcare professionals know what care to offer based on evidence and expert consensus. They're meant to help healthcare organizations measure, assess, and improve the quality of care they provide. And they are meant to help ensure consistent, high-quality care across the province. Next slide, please. Thank you. Included in the quality standard for clinicians is a guide for young people, as well as a guide for caregivers. These plain language guides explain what quality care looks like for young people transitioning to adult healthcare services so that they know what kind of care they should receive and to advocate for it. Next slide. Now, Rob is going to take a deeper dive into what the quality standards say.
Thank you very much, Laura. I always appreciate just understanding the background of how these quality statements come along, and I think you really did a nice job of just showing just how robust this was and how much was involved with it. So we will move on to the quality statements at this point. So first of all, I want you to recognize as we're working through this, you're going to see that there's a little bit of synergy between the six. And as I'm working through each of these statements, you may find that some of your questions are actually going to get referred to a little bit later in them. So that's why I'm going to start off with just the outline of the six statements. So the first one focuses on early identification and transition readiness. Number two looks at information and sharing and support. The third one looks at the transition plan itself. The fourth one is how we coordinate that transition. The fifth one then is the introduction to adult services. And finally, the last one is the transfer completion. You will also notice, though, that as we go through this, there's a chronological order to this. So in terms of, they're not just six random steps, but they're actually, the six statements are in order. We look at doing number one first in terms of time frame, number two, and so on. Next slide. All right, so in terms of the statement itself, the first quality statement looking at early identification and transition readiness is young people who will transition out of child and youth oriented services are identified as early as possible and have regular and collaborative reviews of transition readiness to support their ongoing preparation needs for transition and the needs of their parents and or caregivers. And there's a couple things that I really want to bring out here. The first one is one of the things that we always know in terms of child services is almost in all situations, we know that a child is going to transition from child services to adult services. And we know when that's going to be. It's going to be right in that 18 years of age time frame. There's always a little bit of leeway either way, depending on the service itself, but it's definitely going to be at that point. The key here is making sure that it's identified as early as possible. And I made a little bit of a reference to my earlier experience that with my oldest daughter being diagnosed at 16, we discovered it was too late. There was too many things that had to be done. There was too many people that were involved in terms of being able to even access the services. By the time she turned 18, we just didn't have enough time frame. I will say that her younger sister and her younger brother benefited greatly from that. And as a result, both of them, we began their transition at age 14. And what we have found is with my middle daughter, it worked very well starting that at age 14. We're finding the same thing with my son starting at 16. And then the other aspect of that is recognizing that these conversations don't happen just once. That's where the regular collaborative review piece comes into play, that there's going to be ongoing conversations. They need to happen 2, 3, 4 times, even from ages 14 to 18, in terms of potential goals, in terms of even identifying what the child's need is, will change within that 4-year time frame. And so that's why we need to make sure it's a dynamic process. Next slide. In terms of some of the resources that you can tap into, one of the things that British Columbia and Alberta have advantage over Ontario is they have been doing this a lot longer than we have. There's no doubt about that. In fact, British Columbia and Alberta, they have definitely been capturing their data and writing the reports and so on for really 15, 20 years now. And so when you look at their resources, you really see that understanding, that evidence-based best practices as part of their tools. And so some that we're familiar with is the Youth Toolkit and the Family Toolkit from the BC Children's Hospital. These are live links, and I was thrilled to hear that all of you folks are going to get the slide deck directly after the presentation as well, so that you can access these. Well on your way from Alberta Health Services is if there's one resource that you want to find the time to look through, that is one to definitely look at. From an Ontario standpoint, Sick Kids has done a lot of work around this, and their transitions to Adult Care Learning Hub is also a great resource to look at. One thing that I should point out, which is always really important, at least from a personal standpoint, is these are very much voice first documents as well, where it's the patients, it's the young people themselves, were the contributors in a large extent to the documentation. Next slide. Another one that you may not be familiar with, because it's just came out recently, is My Transition app from McMaster University. It can be accessed through both iOS as well as Android off of Google Play. And this particular one, I think what's important to recognize is my particular organization, Rural FASD Support Network, was actually one of the pilot organizations from the alpha testing standpoint for this particular app, because they were very much interested in making sure that it was going to be accessible for people, even from an intellectual disability standpoint, people from a complex needs standpoint. And so they did a wonderful job, much like Ontario Health, in terms of taking the feedback that we gave them, incorporating it into this app. And so that is one that I would really stress that that recognize it's not designed just for the large majority of our population, which are not dealing with disabilities and other challenges, but it's really suited for everyone. So definitely something to check out. It does a really good job in terms of helping our youth or our young adults stay organized, their contact information, calendar in terms of when their appointments are. Just a really great resource for sure. Next slide. Our second statement is that information sharing and support aspect. And so the statement reads, young people, again with their parents and caregivers where appropriate, are offered developmentally appropriate information and support to meet their needs throughout the transition process. Information sharing is collaborative, and healthcare providers actively seek the experience and expertise of the young person, and again, their parents and caregivers where appropriate, and incorporate it into the transition planning and shared goal setting. And so again, couple of the main terms as we were working through these statements that I want to really bring out here is the developmentally appropriate information. We know from an accessibility standpoint, when we look at the Federal Accessibility Act of 2019, that accessibility is a lot more than just, for example, mobility challenges and so on. Accessibility is as much to do with communication as anything else in terms of even access to where the services are located. And so when we talk about developmentally appropriate information, if the client or the patient is someone who has, for example, receptive language challenges or expressive language challenges, our communication is going to have to be done in a very different way. And so it needs to be appropriate to where the patient or the client or the young person is currently at. And so that's the first piece that I want to bring out. The second one then is that aspect that it is collaborative, that we do want our young people and our young adults to have responsibility for their own care through the rest of their lifetime. And they do know, and I know that as caregivers, you're aware of the same situation, that they know what they need. Lots of times it's difficult for them to be able to communicate it in a way that people understand. Sometimes they may not be aware of what the treatment or the reaction should be, but they definitely know when something is wrong, when something needs to be done. And so that's where that collaboration piece really comes into play as well, and incorporating all of that into the plan itself. Next slide. So the third one is the transition plan itself. And so young people have an individualized transition plan that is co-created, documented, and shared within their entire or their circle of care. And so again, a couple of the key elements here is, number one, that it's co-created, that we are still talking at this point about the young person being below that age 18. We are in the beginning portion of that transition plan. And so as the primary caregiver, you absolutely should have a part in this in terms of, you know your child best. You're going to be able to serve in that advocacy role to a large extent. And so that co-creation is within the three parties of the service provider or the clinician or the medical personnel, as well as yourself and as well as your child. We want to make sure that it's documented, that it is contained so that there's no misunderstanding. There's no changing of what the expectations and understanding is, that everyone has that common document that they can refer to and realize this is what needs to happen. And then finally, that it's shared within their circle of care, that everyone has access to the documentation, to this individualized transition plan. Next slide. There's lots and lots of templates out there when it comes to transition plans. There are a lot of different organizations. These are some that you can refer to. First one by PCMCH is the Youth Transitions to Adult Transition or Health Services, the Transition Discharge Planning Tool. We've got the Complex Care for Kids, the Ontario Youth Transition to Adult Care Toolkit with the Caregiver Checklist and Resource Guide. Again, a really nice one if you find checklists to be handy to kind of keep you organized and understand what type of questions you should be asking. That's certainly a good one. Your Mind Service Transition Plan, moving to adult mental health and addiction services. If this is a area where you're currently or your young person is currently receiving care, again, a really good resource. And then finally, our shared transition plan, talking about transition with young people with developmental disabilities and their families. This is again where we're talking about that accessibility piece, that developmentally appropriate information. Next slide. So our fourth statement is the coordinated transition itself. And so young people have a designated most responsible provider for the transition process. This provider works with the young person and their parents and caregivers where appropriate to coordinate their care and provide support throughout the transition process and until the young person and their parents and caregivers where appropriate confirms that the process is complete. And I'm going to speak to that last part a little bit later and focus more on the designated most responsible provider. And we were very intentional in the language that we used here. First of all, the designated piece is we recognize for a lot of our young people as well that their trust is sometimes can be very challenging. And we know lots of times, even the relationship that may exist at times between our young people or our young adults and ourselves as their parents or their primary caregivers, that relationships can kind of ebb and flow. We recognize, particularly in those ages of 14 to 18, that peer relationships become extremely important, that our external modeling in terms of their friends and the people and the young people that they may be around, it's really driven by where is the strongest relationship that the young person has. And they should have, as a result, that option to explore that individual wherever the strongest relationship may be. And so that's where the designated most responsible provider comes from. It could be one of their medical personnel that they have a really good attachment with, that they have a strong relationship with. It could be someone within their community. It could be someone within their circle of care. It could be someone within their community circle, or it could be someone within their immediate family, such as yourself. But the idea again here is it is driven by that voice first aspect. It's driven by the client or the patient themselves, or the young person in this case is the one that's really going to look at, because the key to it is that relationship needs to be able to carry through until the entire process is complete. From that, we will then look at coordinating their care, providing that support. And again, it's around that piece to be able to communicate that if it's an individual that really understands how they think, what their needs are, they can help with that advocacy piece at times, and then also have the debriefs and the follow-up afterwards so that the young person is able to make informed decisions moving forward. That is really the goal that we're trying to achieve through this particular quality statement. Next slide. Statement number 5, introduction to adult services. Young people and their parents and caregivers where appropriate have a meeting with key adult services or other providers before the transfer to facilitate and maintain continuity of care. And again, what we're looking at with this particular statement is that idea that this transition meeting, this introduction needs to happen before they actually age out of their child services. That this transition meeting has to happen while they're still, whether it's at that age 16, that age 17 or whatever, that's where that transition period is going to happen. So when they do actually turn 18, everything is ready for them. I would really, from a personal standpoint, really stress the fact that really this meeting, you don't even want this one to happen 3 months before they turn 18 or even 6 months before they turn 18. Like, this one needs to be happening far enough ahead where everyone involved is able to ask those questions back and forth. One of the key aspects to recognize here as well is within this meeting, hopefully the opportunity then for consent forms, the documentation that needs to be put in place, respecting the privacy aspect, realizing that the young person is going to be able to have sole consent and determine what level of privacy they would like once they turn 18, that if that happens before they turn 18 and the consents are formed, that you can then, the medical personnel and the clinicians and so on they're able to have those meetings back and forth before the transition actually happens. And so again, and that's where that most responsible provider is going to come into play as well, to help facilitate and coordinate all of those exchange of information and so on if it's needed. In a lot of situations, we know that depending on where what the transition consists of, a lot of our clinics have within their own organization both those services, or you may have to go from one provider to another, but at least it gives that time frame where everyone is prepared and ready to receive your young person once they turn into that adult stage. And next slide, last slide in terms of our quality statements. So the last step, of course, then is the transfer completion. And the transfer completion reads, young people remain connected to the designated most responsible provider for their transition and are supported until healthcare service transitions are complete and confirmed by the young person and their parents and caregivers where appropriate. And so this statement is what it's saying is, again, whoever that person is that has been designated to them and is also seen as the most responsible individual. And again, this could be the general practitioner, the general physician that you have been working with. It could be someone else within their service of care that really understands and has been able to establish that relationship with the person. But the idea here is they don't just disappear when the young person turns 18. They remain connected to the young person until the young person says, I am now comfortable with the care that I'm receiving from an adult service standpoint, that I am now in a position to be able to move forward on a more independent basis. And so again, this is really all around that system navigation aspect. To me, one of the things that we've really found with my oldest daughter is there is that gap that exists between the service, the medical practitioner and the service of care in terms of them being able to communicate what they have to provide and so on, as well as my daughter, who with her disabilities and some of the developmental challenges that she has, the communication that happens sometimes gets lost. And she will at times say, I understand, when in reality she doesn't. And so how do we bridge that gap at times that exists between them? The other part that I found really fascinating around this is my daughter also has lots of friends who are neurotypical of the same age. A lot of them have gone off to university. A lot of them are now professional individuals working in various jobs, able to live independently, able to work independently. And yet you'll hear them make the same type of statement, that when they left their home and they turned 18 and it suddenly fell on them to have to figure out the whole adult service system, they struggled just as much in terms of that system navigation piece and understanding just who to go talk to and what each service does and what their purpose is and so on. And so it's really important to recognize as well that these 6 quality statements are not just from a developmental standpoint. It's literally for every single individual within Ontario who is transitioning from child to adult healthcare services. Every single one of us are finding this challenging right now. And so that's why these 6 statements, we believe, are really going to be able to help move and solve some of the challenges that we're facing right now. Next slide. And finally, I want to also make sure that you know exactly where these quality health standards are located. And this is going to be, from my standpoint, when I think about how many medical folks that are involved with my family between my three kids, I have counted that number. There are 22. I have 22 different medical individuals, whether from a mental health clinician standpoint, from a physical health standpoint, other aspects as well. There are 22. I can assure you that all 22 that I have direct contact with know exactly where these standards are and have been encouraged to look at them. And really, that's why we were absolutely thrilled to be able to come here today and to share with you what these statements are, because we know that as this information becomes more and more aware, and more of our society, as well as our medical personnel, are aware that these standards exist and how to access them and locate them. We also know that there will be communication and conversations that happen within their circles. And so if you share with your direct health your medical personnel, what you want to tell them is to, number one, go to www.hqontario.ca. And if you go there, you'll see a screen. If your browser is similar to the one that we have here, you'll see a screen very similar to the picture down below. And you're going to click on right in the middle there where it says evidence to improve care. And right below that, you're going to click on quality standards. And you can see the blue arrow there where it's got in the blue quality standards. You're then going to click on it, and you're going to go to view all quality standards, which is on the left-hand side. And from there, you will see the quality standard itself, which is in the first part. And we have the blue box there. The red title quality standard is where the standard itself is actually located. There is a brief, a summary version of it, as you notice along the top there. But the other one that we want to really bring out and make sure that you're aware of is there's also a guide for both your young person as well as yourself on that page. So once this presentation is done, I would strongly recommend, if you've got a few minutes, locate these guides, bookmark them into your browser, hold on to them. I can tell you from my own personal standpoint, extremely, extremely valuable resources. And when I can just literally hand a link to any of the medical service providers that we deal with, that is by far the most effective communication that we have found at this point. And so, next slide. And so with this, we are coming near the end of our presentation. As I said before, thank you so much. I certainly know for all of you, our time is incredibly valuable. And we are always constantly making decisions as to where our priorities lie and what is most important and most beneficial in terms of our valuable time. We certainly hope that you have found this presentation to be beneficial for the time that you have been kind enough to give us. If you have any further questions, you can definitely email qualitystandards@ontariohealth.ca. The folks there are extremely responsive, would love to hear from you. Your feedback, your lived experience is so incredibly valuable. And again, I can tell you that in terms of organizations that I have had the pleasure to work with, that lived experience voice that Laura and Michelle and myself have brought with you tonight, we are very much seen as collaborating experts within this entire process. Your voice is just as valuable for the Ontario Health organization as well. And then finally, Ontario Health is actually putting out lots and lots of quality standards. You will see them when you go to the website. You may find that there are others there that are of a great benefit to you as well.
Wonderful. Thank you so much, Rob, and to everyone. for joining us today, sharing your personal experiences and enlightening us on the transition data and quality standards. We have some time for questions from our audience now. We've had a few come in and some great comments as well. So I'm going to invite all of our panelists to pop back on the screen for our Q&A. You can turn on your cameras. And I'm gonna just sort of throw out some questions to folks, and certainly if as I'm going through these questions, and I might direct it at one of you, but if someone else has something you want to add or share, please feel free to jump in. So as I say, there's been some great comments and questions that have come in. One of those comments is this is an excellent resource and it needs to be mandated, not just suggested, which I'm sure a lot of folks have told you or maybe part of your discussions as you're developing these standards. One of the earlier questions that did come in is more around funding, and I'm sure that comes up a lot in your personal lives and in your professional lives. So as we're looking at this transition planning, how do we look to funding for a person who's in transitional age youth or transitioning from youth to adult services? And I'm not sure if any one of you is really jumping to answer that question or has some lived experience with that wants to kick us off. Rob?
Or, yeah, it's a tricky question because I need a little more context, I think, behind what that question is asking for. If I'm interpreting it correctly, it sounds like that maybe they're looking for what potential funding there might be for adults within Ontario. I'm going to make the assumption that the adult that they're referring to probably has some developmental disabilities, impacted by developmental disabilities in some way. There's definitely some of the, I guess the major ones would be ODSP, the Ontario, I can't remember what all the acronyms stand for.
Disability Support Program.
Yes, thank you. Certainly a second big one would be through developmental services, the passport funding is kind of the second main one. In terms of from a children's standpoint, kind of associated with the ODSP is the SSAH as well as the ASCI, depending on income levels. And then the last one I would certainly bring out that folks do not want to forget about is that the federal level, the disability tax credit. And there's a lot of work being done around that. Lots of announcements coming out here recently in terms of just even criteria and eligibility aspects involved with that one. I can tell you that when it is, all of them are certainly a very difficult journey. I will leave it at that. If you have someone to tap into that understands how to do those forms and those applications, I would certainly use that resource as well.
Thanks, Rob. Lots of acronyms out there that we have to navigate. Any other feedback or thoughts from the rest of the panel on that?
Yeah, I'll just jump in for a second. I think from my perspective, for those who I guess parents who and caregivers who have supported a youth transitioning to adult care for eating disorders, I think there are very little financial supports available. Other than what you mentioned, Rob, I think that some of those are there under certain circumstances. But for the majority of people, and what my experience was and experience of many people I've talked to, really it comes out of your own pocket and your own ability. And that was really challenging. You know, me having to leave work as an example, and I am just one of, you know, hundreds of parents who have to leave work, leave my career, go into debt. But, you know, what we have to do for our children when we have the capability to do that, you know, I think it's a real challenge, and it's a barrier to care. It's a barrier to actually being able to achieve recovery in the long run, and a barrier, I think, also to achieving quality standards. I mean, when there just aren't the resources in place and the support to parents until we really, you know, address those underlying issues of access to care, of continuity of care, of acknowledging that, you know, eating disorders are a serious mental illness that are not a choice. As with many other mental illnesses, it's going to be a challenge.
Thanks, Michelle.
You're welcome.
Anyone else have thoughts on that? Kristen, please.
Yeah, this comes up every time we talk about transitions. I look at Rob and Laura. And the one thing, that I suggest is that we can use the standards to advocate. I know not that we are not advocating, but I often say, bring them into your clinician and say, these are the Ontario Health Standards. Is this organization supporting these things? How are you preparing my child for transitions? They have a little bit of oomph in them, the Ontario Health Transition Standards, myself, both as a clinician at the hospital side, but also as a caregiver myself. They're at least something that we can look to start to utilize in addition to the other advocacy that's happening. Mm-hmm. I do know that these have been communicated to the powers that be, that they are a first step in terms of advocating for what basic standards need to be in care. And there is, even in the 20 years I've been doing this research and clinically, there has been a shift to really at the healthcare, community health, and the funding model about the importance of transitions. We're not there yet, and this is just one step. And I would say also strong advocacy from organizations is the other. I think it's a more important step, but this is one piece of that pie or puzzle.
Mm-hmm. Thank you. That's great. It is really helpful, I think, to have something to walk in to advocate with. We all know what we want and feel we need and our people need, but it's great to have something that's a supported document that, as you mentioned, was co-designed. And it might be helpful to quickly mention that and maybe acknowledge the folks that put the work into this. I know we're running low on time, but I think it's really important. And Kristen, maybe I might invite you to share a little bit more with our audience. What does co-design actually mean? It was mentioned in the talk. And share briefly who was involved in creating these standards so that folks know who the powers are behind, bringing this forward.
Yeah, so we are quite proud. So I won't speak individually, but with Laura and Rob here, and then my co-chair, Len, who's a pediatrician, adolescent medicine physician at Sick Kids, of how integrated at every stage are. It's not even, we didn't refer to people as expert advisors or caregivers or youth. They were just part of the panel. And I would say, I have initially, when I was approached, I advocated strongly that I couldn't move forward with leading this if we didn't have a strong group of caregivers and youth. So we had several caregivers, Laura and Robert here, and then we had 3 youth that represented the mental health, physical health, and complex health. So we had a pretty good balance of caregivers and youth, to clinicians from the community, physical, mental, complex health, and hospital, as well as then managers, service providers. I'm really proud of the panel that we put together and the work that we did. Then we took it for hundreds and hundreds of consultations, and we reviewed the balance of who was responding to those consultations. And in one instance, we noticed there was really a lack of youth from mental health backgrounds. And so we worked with Ontario Health, thank you, Carol and Dana, to seek out more opportunities to get feedback on that. So there's been, and yes, we did have representation from families from eating disorders and youth. Len Tulini actually works within that sector at Sick Kids as well. So the mapping of the areas of expertise and engagement and consultation was really important with this standard. And I understand that Ontario Health has actually, for future quality standards, has moved towards the co-chair being a patient or caregiver, which to me is really exciting. So I think, and then we do have a summary report of everywhere that it went out to. I believe it's on the website. I'm looking to Dana, but she can't see me looking at her, but there was quite a large consultation for.
Thank you. I think it's really important for folks to understand the work that goes into it and the people that play a part in this. This is something that journey might be not the greatest representation, but it's certainly something that takes time and energy and passion and commitment. So I think it's important to acknowledge that. We are a little bit over time, but I do want to ask a question of all of our panelists. It's come up in a comment and come up in a question, and I'm going to wrap it in privacy and consent. So we know we are bound by, privacy and consent laws as a person, and it was mentioned in some of our personal stories that, this person now can make their own choices, but I am a passionate, loving, caring person in their life, and I have things to contribute as well. I'm wondering if you have any tips, some quick thoughts and tips on how to navigate that as a person is transitioning into adult services and has capacity to make their own choices and decisions. What, if anything, have all of you done or have tips for our audience on how to navigate those conversations and those appointments and things like that? So I might invite Laura to kick that off, and then I'll go quickly around the circle.
Sure, thanks. I'm not sure my answer will be as helpful maybe as the other two answers, because my son had a significant intellectual disability and was non-speaking. So he was not going to be able to provide consent, and we had guardianship and the appropriate documentation done to be able to do that on his behalf. Applying for that is a challenging and frankly difficult process. It's expensive as well. It costs significant funds to do that. So we had that kind of paperwork done so that we could then advocate on my son's behalf during hospitalization. What I sometimes found was that in the adult system, the default is not to include the parent. Is not to include the primary caregiver, which in our case was me. And so I often had to assertively advocate to be able to be part of those conversations. And what worries me in those circumstances is that it does place a great burden on the primary caregiver to be able to do that advocacy work. And sometimes situations don't allow for that. They're fraught. And I'm thinking of the 2 ICU admissions my son had before he died, where we were navigating a very complex acute care situation with significant healthcare decision making happening in pretty rapid time. And for me to have to be able to advocate within those environments to make sure optimal care was ensuing sometimes was challenging. So a little bit different in my story. I imagine Michelle and Rob will have slightly different answers because I assume their children are more able to be engaged. Their adult children are more able to be engaged in decision making.
Thanks, Laura. Michelle, do you have any quick tips or takeaways we can leave our audience with around privacy and consent navigation?
Yeah, within the world of eating disorders, as well as many illnesses, physical and mental, parents don't cause them, but they are key to recovery and key to ongoing support. So our challenge was being able to become part of that care team. Doing that, I think we built the relationship and with the medical team while she was an inpatient at a children's hospital, at the Children's Hospital of Eastern Ontario. And we worked closely with the doctors to always kind of get to yes at the best that we could to get to her consent. And we just started that relationship while she was in hospital, and very fortunate that she was open to continuing that when we transitioned to private care. So, yeah.
Thanks, Michelle. Rob, any privacy tips? Big question, real short answer.
Very short answer would be the importance of being able to maintain relationship with your child, no matter what the situation is, no matter what you go through, no matter any of it does not matter. Always, always, always keep the door open in terms of communication. Always keep the door open in terms of whatever decisions and choices are made, that they always have that safe home to come back to.
Great, wise words to leave us on. Thanks, Rob. So that is all the time we have for today. And I do want to thank all of our panelists again, Rob and Laura, Michelle and Kristen, for joining us tonight and being so open about your caregiving experience and the challenges and the successes within the transition planning And of course, for all of the work that you've done as part of the Quality Standards Committee. This is wonderful information.